INSPIRE-1 feasibility was a proof-of-concept study in 8 subjects. This trial demonstrated that nightly stimulation in moderate to severe obstructive sleep apnea, the same population as the STAR trial, decreased apnea severity without waking patients from sleep. The location of the sensing lead was moved to between the intercostal muscles to minimize surgical risk and improve performance. The INSPIRE-2-3 Group 1 feasibility study was in 22 subjects. This study established the viability of the inspiratory pressure sensor placement between the intercostal muscles, and as Tim Herbert noted, this study also identified predictors of therapy success, which were an AHI less than 50, body mass index less than 32, and absence of concentric collapse on drug-induced sleep endoscopy, or DISE. The INSPIRE-2-3 Group 2 feasibility study validated that narrower selection criteria developed from the feasibility Group 1, and these selection criteria were used in the STAR pivotal study. Picking up with the study design overview, the major inclusion criteria included moderate to severe OSA based on history and physical, or a diagnosis of OSA based on PSG within the last 12 months. Subjects also had to have been documented to fail CPAP or be intolerant of CPAP. CPAP failure was defined as an inability to eliminate OSA, for example, an AHI greater than 20, despite CPAP usage. And CPAP intolerance was defined as inability to use CPAP as documented by less than 5 nights of use per week, where usage was defined as greater than 4 hours of use per night, or unwillingness to use CPAP, for example, a patient returns the CPAP system after attempting to use it. We note that the AASM recommends that BiPAP or bi-level therapy is offered to CPAP failing patients, but that requirement was not included as part of the STAR trial. This is not an exhaustive list of the exclusion criteria. The complete list can be found on page 27 of the FDA Executive Summary. The main exclusion criteria included body mass greater than 32, prior surgical resection or radiation for cancer or malformations in the larynx, tongue, or throat, absence of concentric collapse at the soft palate by DISE, hypoglossal nerve palsy and fixed upper airway obstruction, and prior upper airway surgery performed within 12 weeks. Note that the qualification of within the last 12 weeks in the exclusion criterion allowed for enrollment of a significant number of subjects with a prior history of upper airway surgeries, including uvulopalatal-pharyngoplasty, or UPPP. Drug-induced sleep endoscopy was used to rule out concentric collapse at the level of the soft palate, and Dr. Khan will describe this procedure in more detail when she presents the safety results. The follow-up and data collection table can be found in Table 8 on page 25 of the FDA Executive Summary. After successful pre-implant screening, subjects were implanted with the INSPIRE system and allowed to recover for 1 month. At 1 month, a second in-lab sleep study was conducted prior to activating the INSPIRE device. As noted by Dr. Strollo, the results of this 1-month sleep study and the pre-implant sleep study were averaged together and defined the subject's baseline parameters. Regular follow-ups with performance of PSG studies occurred at 2, 6, 12, 13, and 18 months. PSG was not required at the 3, 9, 15, or 24-month follow-ups or beyond. Adverse events were evaluated at each visit, and Dr. Khan will present more details regarding those evaluations. This slide goes into more detail regarding device programming and stimulation adjustments. The initial device settings are programmed during an office visit. Additional adjustments are made per protocol during an overnight sleep study where real-time review of the PSG data is used to guide device adjustments during the 2- and 6-month visit. During a PSG study, stimulation strength may be increased if persistent apneas and hypopneas occur. Device stimulation and sensing parameters could be adjusted in response to acute observations made during the PSG study and to overall therapeutic efficacy as indicated by the PSG results. Adjustments were not allowed within 30 days of the 12-month PSG or during the 12-month PSG. Similarly, adjustments were not allowed during the 13-month PSG or during the randomization period prior to the 13-month PSG. Of note, while PSG-guided titrations were scheduled at 2 and 6 months, many patients also experienced therapy and setting adjustments throughout the study for discomfort and stimulation issues. Later, we will present additional patient data regarding the additional titrations. The panel will be asked their opinion regarding the impact of additional titrations and system settings changes on the evaluation of long-term durability of effect. Jason Schroeder already told you about the primary and secondary endpoints as part of the statistical analysis plan. The FDA also requested that the sponsor provide summary statistics regarding sleep architecture and to draw correlations between quality of life measures and sleep parameters. That concludes the study design overview, and now I will present the STAR pivotal trial results. This slide summarizes the patient accountability, where there were 929 subjects screened, of which 126 were implanted with the Inspire system. Among the 803 subjects that were withdrawn pre-implant, 108 subjects did not meet inclusion-exclusion criteria during the baseline examination for eligibility. The majority of withdrawn subjects were disqualified due to the screening PSG. The most common PSG exclusion was for an AHI less than 20, followed by an AHI greater than 50, then a high percentage of central or mixed apneas, and finally positional obstructive sleep apnea. Surgical consultation disqualified another 13 subjects, and the DICE procedure further disqualified 56 subjects exhibiting complete concentric collapse at the level of soft palate. An additional 97 subjects were disqualified for reasons including withdrawal of consent, enrollment termination when implantation cap was met, loss to follow-up, and other reasons. Of the 126 implanted subjects in the STAR trial, 87 were implanted in the United States, and the remaining 39 subjects were implanted in Europe. A valuable data was collected on 124 of the implanted subjects, and 2 were lost to follow-up. The demographics of the 126 subjects were comparable between responders and non-responders for age, gender, body mass index, and neck size. Of note, 83% of subjects were male and 97% were Caucasian, with 0 African Americans, 1% Asian, and 1% Hispanic. Sleep disordered breathing can be twice as prevalent in African Americans aged less than 25 and is more prevalent in African Americans over age 55 compared to Caucasians. The prevalence of OSA in Asians is comparable to Caucasians, yet Asians tend to have more severe disease. The panel will be asked their opinion regarding whether the information derived from the study population can be extrapolated to the intended population of CPAP failure or CPAP intolerance. Evaluation of comorbidities revealed that hypertension was the most common condition among the implanted subjects, followed by diabetes, asthma, congestive heart failure, stroke, and COPD. Looking specifically at subject OSA medical history, we see that just over 1/4 of the subjects had used an oral appliance such as a dental or non-surgical mandibular advancement device. In addition, some subjects had previous sleep surgeries that were not effective at the time of the enrollment. For example, 18% of subjects had prior UPPP surgeries and 6% had tongue-based procedures for treatment of OSA. This is a table of baseline characteristics in responders versus non-responders. The study population consisted of subjects with moderate to severe OSA. The demographics were similar between responders and non-responders with the exception of prior UPPP. The percentage of patients with prior UPPP is almost twice as high in the responder group compared to the non-responders. We note that although the applicant's statistical analysis demonstrated that the difference in UPPP rates in the responder versus non-responder group was not statistically significant, the FDA is unsure of the significance of this trend. The panel will be asked their opinion regarding the significance of the trend for increased history of UPPP in the responder group and whether prior upper airway surgery should be considered as candidate criteria for the Inspire therapy. These are the results for the co-primary endpoints. The trial achieved the primary effectiveness endpoint. These analyses are based on the intent to treat group, and the 2 subjects not completing the 12-month evaluation were treated as non-responders. The performance goal for the co-primary endpoints of AHI and ODI was a 50% responder rate. The measured AHI responder rate at 12 months was 66%. The corresponding lower confidence level of 57% was above the pre-specified performance goal of 50%. The measured ODI responder rate at 12 months was 75%, with a corresponding lower confidence level of 66%, which was also above the pre-specified performance goal. In addition, the results at 18 months were consistent with the 12-month results. At 18 months, the AHI responder rate is 65% and the ODI responder rate is 80%. Again, lower confidence levels were above the pre-specified performance goal of 50%. Here are mean results for all the primary and secondary endpoints. mean baseline AHI was 32, and the mean AHI at 12 months was 15.3, which corresponds to a 50% reduction, and at 18 months, the AHI was 14.1, with a mean reduction from baseline to 12 months of 16.7. Baseline ODI showed a mean of 28.9, and at 12 months was 13.9, which corresponds to a 49% reduction from baseline. At 18 months, the ODI was 12.7, corresponding to a 53% reduction from baseline, and the mean change in ODI from baseline to 12 months was 15.7. The FOSQ score at the pre-implant visit was 14.3. FOSQ at 12 months was 17.3 and was unchanged at 18 months. The mean change in FOSQ was 3, which was statistically significant from baseline to 12 months. Literature defines an improvement of 2 points in the overall FOSQ score as clinically relevant, and a score above 17.9. The ESS score at baseline for 126 subjects was 11.6. At 12 months was 7, and at 18 months was again unchanged at 7. And the mean change between baseline and 12 months for ESS was 4.6, which was statistically significant. An ESS score of less than 10 is considered normal. The percentage of oxygen saturated sleep time with oxygen saturation less than 90 at baseline was 8.7, at 12 months was 5.9, and at 18 months was 5.6, with a mean change from baseline to 12 months of 2.8. The following slides will present results of the randomized controlled therapy withdrawal study. Remember, as Dr. Strollo stated, the device was off for 7 days and then turned back on after the 13-month PSG assessment. In this figure, the mean AHI is on the y-axis and time points on the x-axis. The therapy on group is in green bars and the off group is in red. Following therapy withdrawal for the off group, the mean AHI increased from 7 at 12 months to 25 after therapy was turned off, shown in the red bars. The mean increase in AHI post-withdrawal was 16.4, which was statistically significant. The green bars show the change in AHI for the on group, demonstrating sustained reduction of AHI with therapy remaining on. 18-month efficacy data was evaluated in the 46 subjects who completed the randomized controlled therapy withdrawal study. In this figure, the x-axis is the AHI and time again is on the y-axis is the AHI and time is on the x-axis. After the withdrawal period, the therapy withdrawal or off group had their Inspire therapy reactivated. This slide shows the progression of the primary endpoint, AHI, from baseline to month 12, then therapy off, and then therapy reactivation for the on group in blue and the off group in red. These numbers are median values. However, what is important to note in this figure is that AHI increased in the therapy off group at the 13-month PSG and then again decreased once therapy was turned back on. The therapy maintenance or on group maintained a low AHI through 13 and 18 months. I would also like to draw your attention to the fact that although AHI remained low at 18 months for the therapy on and off groups, there appears to be a trend for the AHI to increase slightly in the long term. At 12 months, AHI decreased to 12 from a baseline of around 30s, and then during the randomized withdrawal period, slightly increased for the on group to 8.9, and then at month 18, so that range is about 9, and then month 18, it slightly increased again to a level about 10. This is data for the subjects who completed the randomized controlled therapy withdrawal study. FDA calculated the mean for all responders for the 18-month data, and the mean AHI at 18 months was a little bit higher than what's on this slide at about 16.5. This trend is certainly small and may not be statistically significant. However, we would like to point the observation out to the panel. I would now like to go back and discuss in more detail the stimulation adjustments. As noted earlier, the study allowed stimulation adjustments to occur up to 1 month prior to the 12-month PSG. Many subjects required multiple titrations over much of the study to achieve a therapeutic level of stimulation and to address neurostimulation discomfort. The multiple titrations throughout the study affected our ability to assess the durability of the Inspire therapeutic effect. The FDA therefore requested data on stimulation adjustments at each time point for all subjects as well as data out to 18 months in order to further evaluate the stability and durability of the therapeutic effect. Although the applicant reported a mean duration of stable settings without programming changes of 250 into the 18-month visit, the range was quite large with a minimum of 36 days and a maximum of 469 days between the last titration and the 18-month visit. The following slides will illustrate the extent of additional titrations that several subjects required for various reasons. This is titration data for subject B1, which can be found in Table 18 of the FDA Executive Summary. Let me walk you through this very busy slide. The leftmost column are the time points. So the first column is the months, and the second column is the actual date. The next few columns are the device settings, which could be adjusted with amplitude here in volts, lower and upper limits of amplitude, the rate in hertz, pulse width in microseconds, and then AHI and percent change in AHI from baseline for each time point, and then ODI and percent change in ODI from baseline to each time point, and then the reason for the titration of programming. So for this subject, at baseline, the initial setting was 1.4, and at the scheduled month 2 PSG titration, the amplitude was adjusted to 1.6 with lower and upper limits set to 1.3 and 1.8. The rate was 40 and the pulse width was 90. During month 3, there was a scheduled device check where the amplitude was decreased from 1.6 to 1. And then at month 6, which was another scheduled PSG titration visit, it appears that the amplitude was again slightly increased back up to 2.2, and the lower and upper limits were changed. Also, the rate appears to have been decreased slightly. At month 9, there was a scheduled device check where again the amplitude was slightly decreased to 2.1. And then sometime shortly after month 9, during the same month, amplitude was again adjusted slightly upwards to 2.2, and it appears that the lower and upper limits were also changed. Then, after that visit and before the 11-month visit, a stable setting of 2.4 was achieved, which resulted in a therapeutic response meeting the primary endpoint with a 70% reduction in AHI. And at 18 months, it appears that the settings were changed down to 2.2, and the maintenance in the AHI reduction was achieved. So from this data and the numerous titrations, it appears that the subject may not have experienced a clinically significant reduction in AHI until at least the 9-month time point. Now, we do note that the sponsor did explain that the AHI for these interim visits may not necessarily be accurate because active titrations were going on throughout the study night for those PSGs, and that really only the 12-month time point reflects the AHI response. This is titration data for another subject, C17, showing that adjustments were made up to and beyond the 9-month visit. This subject at month 10, where settings appeared to have been adjusted and resulted in a therapeutic response. This subject, K11, experienced 3 interim visits where settings were adjusted, 2 of which occurred after the 9-month time point. Settings were changed at months 3, 5, 6, 9, and 10. In addition, for this subject, it appears that the performance goal of a 50% reduction in AHI was not met until the 9-month time point, and then at 18 months, there appears to be a decrease in the effectiveness where AHI increased to 47 from 15 at the 12-month time point. So the study protocol scheduled titrations to occur up to month 6. However, because settings were adjusted in order to address subject discomfort, titrations occurred more frequently throughout the duration of the study. The need for multiple titrations, which were variable across subjects, affected our ability to assess the long-term durability of treatment. There were several subjects in the responder category with similar data patterns, and approximately 14 in total. The panel will be asked their opinion regarding the effects of multiple titrations and stimulation adjustments on the evaluation of long-term durability of Inspire therapy. This table summarizes the number of titrations in the responder versus non-responder group. The non-responder group experienced more titrations compared to the responder group. This is consistent with the sponsor's explanation that the non-responders required additional titrations in attempts to elicit a therapeutic response. However, if we look at the number of titrations in all subjects, we see that 43 out of 126, or roughly one-third of all subjects, required 4 to 5 titrations shared between the responders and non-responders. This raises the question of how many titrations will a patient need in a lifetime of use of the device, and will the need for titrations increase or decrease with time as fibrosis around the nerve develops? From the current data, the answer to this question remains unclear. As you can see, the amount of time with stable settings varied with each subject. This made it difficult to assess the durability of the therapeutic effect. For example, from the data provided thus far, it is unclear how many titrations and stimulation adjustments will be required for the lifetime of the use for the device. Dr. Khan will discuss this in more detail, but the FDA remains concerned that although the non-serious adverse events, for example, stimulation discomfort and tongue issues, resolve, they are frequent and recurrent and require ongoing adjustments. As noted earlier, we were concerned about the trend for the responder group to have had increased history of UPPP and prior upper airway surgeries. An independent analysis was performed by Jason Schroeder, our statistician, to determine if prior history of UPPP and other upper airway surgeries was associated with increased chance of success with Inspire therapy. Data on this slide is for responder rates based on any prior upper airway surgery and for history of prior UPPP. For example, the responder rate for subjects without any prior surgery was 63%, and with any prior surgery was 68%. This was not a significant difference. The responder rate for subjects without prior UPPP surgery was 63.5%, and for those with prior surgery was 77.3%, and this difference was not statistically significant. From FDA's analysis, we concluded that although there was an observed trend, a prior history of UPPP and other upper airway surgery was not associated with a higher success rate for Inspire therapy. Inspire's own regression analysis is consistent with this conclusion. The following slides will show data on the effects of the Inspire therapy on sleep architecture. The FDA requested summary statistics on sleep time and sleep architecture to determine the effects of Inspire therapy on sleep quality. Overall, there were statistically significant changes in sleep stages. From baseline to 12 months, there was a reduction in total sleep time with reduced sleep time in N1 and N2 sleep. The slow wave sleep increased at 12 months, and REM sleep did not change. There was also a 49% reduction of arousal index from 28.9 to 14.8, which was statistically significant. The following table compares sleep study measures from the 12-month to 18-month PSG. Total sleep time, sleep stages, and arousal index all remained unchanged from 12 months to 18 months. So it appears that sleep quality and sleep architecture were not adversely affected by the Inspire therapy. In conclusion, while the STAR trial met all of its endpoints, the FDA has difficulty evaluating the durability of the therapeutic effect due to multiple titrations throughout the study. Although the non-serious adverse events such as stimulation discomfort or tongue discomfort resolve for the most part, such events appear to be frequent and recurrent in the long term. It is unclear how many device adjustments will be required in long-term use and whether non-serious adverse events are expected to increase, decrease, or remain constant. Inspire therapy did not appear to adversely affect sleep quality or sleep architecture. With that, I would like to introduce Dr. Angie Khan, who will present the safety data.